Hello and welcome to this evening's internal medicine webinar. Following popular demand, we are bringing you the second instalment of how to manage complicated clinical endocrine conundrums with the brilliant Professor Rob Foale. If you missed the first part of this webinar, we'll be sharing the link of the recording in the chat box for you to catch up at a later date, and this can also be found on our YouTube page. For those of you who don't know me, my name's Lydia Morgan, and I'm one of the commercial managers here at VVS, and it is my pleasure to introduce Rob to you tonight. Rob is an RCVS and European specialist in small animal internal medicine. He qualified from the RVC in 1996, and after some time spent in truly mixed practice, he undertook his residency in small animal internal medicine at the University of Cambridge, before becoming a recognised specialist in 2005. Rob joined Dick White Referrals in 2003, where he set up and ran the internal medicine and medical oncology services until 2016. He became a partner and clinical director at Dick White's for 5 years before leaving in December 2021. He's been involved in teaching at the University of Nottingham since 2008, and he has been a professor of small animal medicine at Nottingham since 2020. We're so lucky to have Rob on the VVS team and presenting this topic for us this evening. At VVS, we're on a mission to increase the collaboration between first opinion vets and specialists. We empower first opinion vets to work in real time together alongside our specialists to deliver referral level care to their own patients in their own practice. Our goal is for you to see our specialists as an extension of your own clinical team. We at VVS are also really excited to be expanding our virtual support as we launch our brand new internal medicine mentorship program. Led by our very own Rob Foale, this internal medicine mentorship program will be providing tailored support and personal guidance to help you to achieve your own medicine-related career aspirations. Working together with Rob, you can choose your own unique goals to help you become the clinician you want to be. Now, I know everyone is very keen to get started with tonight's webinar, but before we jump into tonight's topic, I'm just going to ask Rob a few questions about our new VVS mentorship program, if that's all right with you, Rob.
Absolutely fine, Lydia. Hi, everyone. Nice to see you.
So, Rob, just to start, in your own opinion, what vets in what stage of their veterinary career would benefit from the VVS mentorship program?
I hope everyone or anyone would benefit, Lydia, in all honesty. The aim of mentorship is to really support colleagues to become the vet they want to be if they've got areas where they would like to improve. So although the focus obviously with me is going to be in internal medicine, a lot of the things we'll talk about, you could apply to other areas as well. And I would like to bring my experience. I'm well aware I'm quite old now compared to some of the people on the meeting tonight. But I hope I could bring that experience of having been in general practice and loving it through the residency and then up to ultimately running a really large veterinary centre. So I understand, I think it could be for anyone at any stage of your career, and I'll do my very best to help you get to where you want to be.
That's brilliant, thank you. And if people are wondering, what format will the sessions take and how will you individualise the mentorship?
So what we'll be doing, everyone, is we'll be running firstly once a month, sort of a live session within the group, where I will present a little clinical conundrum, a bit like the ones we did sort of previously, and we'll do tonight, to just get you thinking and to work through some genuine real life clinical problems. But as the program goes on, I'd hope the people, the mentees, will actually bring some of their own cases to these sessions as well, and we can talk about everyone's cases and help solve each other's problems. And if I get it right, I'll end up talking less and less. I know that's hard to believe, but I will talk less and less as the sessions go on. We'll also do a quick review of a paper of some sort, and I don't want that to sound too onerous. But we'll maybe do a key paper of something, or we may do a review article, or possibly also some consensus papers. Do one a month, that's all. So where you can get the people on the mentorship program will be able to get a good idea of what the views of other specialists and colleagues around the world are, just to help. That will then create another group of literature people can read if they want to, but there's no obligation to do that. In terms of individualization, though, what we'll also be doing is holding another once a month session where it's a one-to-one, just meeting with me and the mentee. And what we do in those sessions will very much run by what the mentee would like to do. So if there's particular areas that I haven't explained properly or that we want to delve into more detail, we're better talk about those. Maybe some problem area cases that people are really struggling with. Through to, if you're sitting a certificate, maybe we could even do some practice vivas to help with people that come up to synoptic exams. So we will try to, everyone, you need to tell me what you want to do in those sessions, and we'll then try to make that as tailored to each individual as we possibly can. My job, though, and certainly the job of VBS, to make sure we're still doing a rounded education. So I won't do 12 sessions on anemia, as in a silly example, but we'll try to cover everything we possibly can and make it a good rounded program.
Brilliant. It sounds so exciting, and the breadth of opportunity as well with these sessions. It'd be good to know, with your enthusiasm for the subject, what aspects of the VBS mentorship program are you most looking forward to?
I have to be honest, the first thing I'm really looking forward to is meeting new colleagues, and hopefully making some really good professional friendships with people who some of you I may know, some of you I don't know at all. I really love being a vet. I love meeting other colleagues. And I also gain from that. I learn the struggles you're having and seeing cases in maybe a different way from me. So I will grow and learn through this process as well. So I'm actually really looking forward to doing that. The other thing is just being able to share my love for what we do and hopefully watching everybody grow. I get great satisfaction from helping people, but become more the clinician they want to be, and either demystifying or removing problems that people have. So those are the real two aims that I have, and what I'm really looking forward to doing.
Fantastic. And if someone's on the fence, a bit unsure, what would be your advice for them?
Well, I guess classic Rob advice: go for it. Come on up, go. What we're doing is we're running a few little, if you haven't, if you're not sure, we're running a few little, we're calling them taster sessions. What they really are is just a half-hour chat with me and you, so I can get to know you a bit better and understand what it is you're wanting, and then we can talk about how we could achieve that, and also a chance for you to get to talk to me for half an hour and think, God, do I really want to spend a couple of hours of my life with this man a month? Or hopefully see that we can build a relationship that will be work beneficial for you and then for VBS. And I think the other thing that we haven't talked about here, Lydia, is that I think it will strengthen your relationship and your ability in the way to use VBS. That if we can get your knowledge to improve, you'll actually be able to use us for different sorts of advice. So maybe we can shorten your advice course slightly because you'll be asked the questions, but then you'll be able to ask more detailed advice. So we're looking forward to strengthening and developing those relationships, both personally and with the company.
Fantastic. Well, that's really insightful. I hope everyone has a bit of a better understanding of the mentorship program, and I'm sure have similar feelings to me in that you just are wonderful to work with, and I'm sure they're all very excited to do so. If anyone is interested in signing up for the mentorship, we're going to put a link in the chat box, which just you can complete to register your interest. Just to cover what tonight's session is, Rob will be covering a number of endocrine clinical cases. After each case, we're going to have an opportunity to ask questions at that point. So if you have any questions during the case, please add them to the chat box, and we'll do a little question session after the first case and then again after the second, just so you don't forget your cases and the questions for each case, and you'll make sure that all of your questions get asked. So thank you everyone for bearing with us and allowing us to have this introduction and telling you all about the mentorship program. And without further ado, I'm going to hand over to Rob for tonight's fantastic webinar. Thank you, Rob.
Lydia, thank you very, very much indeed. It's really kind of you. And thank you everyone for joining us. I'm really, really grateful. I'm well aware you probably had a crazy busy day in the clinic. I promise I will do my best to stick to time tonight. So I have a stopwatch next to me here, and I will do what I can not to overrun into your precious evening time. But thank you for joining me. Place again for this evening is I'm going to run through two cases, which I hope you'll find interesting. For those of you, if any of you weren't able to be with us in the for part one, I'm going to present these cases sort of in this problem-orientated medicine fashion. Some of you know that, some of you probably practice this, but if it's not something you're used to, basically what we're going to do, the problem-orientated medicine is quite simple. We take the clinical history and then also your clinical examination findings, and we create a list of problems that each patient presents with. And then what we aim to do is we then aim to create a not necessarily exhaustive, but as a reasonable differential diagnosis list for each of those problems. And then we can prioritize those differential diagnoses to what you think are the top 3 most likely things, for example. And then that gives us a really good way of provocatively or directly testing that patient through be it urine, be it through blood, through imaging, or whatever other things we think we need to do, so that every time we do a clinical test, we're asking the test a question. So we're not just going to do a blood sample and see what answer pops out of the biochemistry machine. We're doing a serum biochemistry to prove or disprove our theories to what is wrong with the patient. And the advantage of doing this, it gives us a patient-centered approach. that will be unique for that patient. It gives a very logical pathway. And also, particularly if you get results you weren't expecting, it helps us to interpret that more accurately as to whether we can run with it or we can ignore it. So as I've said this before, it's the you know what to do when you don't know what to do sort of solution. And it's it is a slightly different way of thinking to that you have when you're in a really busy clinical practice. I think I've said this before, if I have a busy day, I have 5, maybe 6 patients, I'm absolutely slammed. You guys have just finished your first half of your morning consult list. So you can't think like this in every patient. But if you get the patient where you don't know what to do, where you're stuck for a solution, this is the way into these patients, because there's always an answer. Normally the hook comes from the history and the physical examination. So that's what we're going to do. So put this diagrammatically, you've got the owners presenting complaints in history and the clinical exam findings. And if any of you are seeing a second opinion, or certainly for me in a referral clinic, I've got another list, which is the referring vets problems. And we need to consider each one of those. When we create a problem list, when you start getting good at this, we can prioritize that problem list, determine what you think you really need to answer first. Create a differential diagnosis list. And I think if you just your top 3, so you don't need to know anything else, just what you can look that up in a book. And then we can make a specific plan of what is the most sensible thing to do and what questions are we looking to answer with the test that we're going to do. Okay, because that's really important. Now, hopefully we come down to the left-hand side diagram here, we reach a diagnosis and you treat and we're all sorted. But if you don't get a definitive diagnosis and your initial tests disprove your theories, you go around the right-hand side or on the slide here, we review the problem list. We maybe make a more in-depth differential diagnosis list or think of things that aren't quite so common, and we go back and then test for those. So and what I've basically got on this slide is that is what we do in referral clinics and specialist clinics. This is the way we work through every single patient. So I hope that's again, it's a slightly different way of thinking from your normal everyday, very rapid decision making, diagnosis making that you do in general practice brilliantly well. Never underestimate the skill you have in that, guys. But this is how I'm going to present the cases for you today. So moving straight into a case. Sam was a really very special patient to me because he actually ended up leading into a big research project, which I'll very briefly mention at the end of his case. And he was a really fascinating example of, I don't know how many times you see this, but he had the same disease as his owner. And I see this quite a lot, to the point it's a bit spooky. I remember the best example of this, not on an endocrine, was a dog who had primary polycythemia. And I've been treating him with hydroxyurea, not a very common chemotherapy drug, and it was quite hard to get hold of. I remember on Friday night, the owner rang me and said, Rob, I've run out of his medication. I went, oh, crumbs, knowing it would take me at least 3 weeks to get hold of this, we're having to do imports. And so I said, well, that's never mind. Okay. He said, well, can I give him one of my tablets? What do you mean? And then she confessed, she said, never told me, but she's got had exact the same rare blood disorder as her dog. So I'm fascinated when I see this. But anyway, back to endocrinology. Sam, as you'll find, had the same disease as his owner. And this is him. This is a picture of Sam, actually, he's a lovely little dog. And he presented, actually was a classic Friday night presentation. And originally he was referred for vomiting, and being very dull and lethargic, and the felt that he needed some intense fluid therapy and was worried that he wouldn't be able to look after him well overnight. So when I talked to the owner, actually it was Mr. at this stage, but I got to know Mrs. Can't say Mrs. W very well, and that they reported he was completely normal about 2 weeks ago, but actually they'd noticed over the past sort of 10 to 14 days he'd started to drink much more, and he was urinating more. To the point that they were getting a bit frustrated, and to open the back door and let him out into the garden. And then he also thought, I quizzed him today, anything else has changed? He said, yeah, his appetite has changed. That they thought of the last sort of week to 10 days, he was certainly wanting to eat more. He was bugging them for food, and they thought, eating more quickly. But that he then stopped eating 2 days before, and then the vomiting had started on that Friday morning. So that was the history I was presented with. And probably same as you, that the question you've got here for owner says the dog is drinking more, is you need to try to quantify that. And you're probably the same as me. You say, oh, well, how much do you think they drink each day? And they went, well, his bowl's about this big. And you and I have obviously been taught at vet school to magically know how the volume of every water bowl that dogs can possibly drink from. But most owners can't tell you. So what we need to say is, well, do you think it's 2 to 3 to 4 times the normal? To at least get some idea of what sort of how dramatic the change is. And Mr. and Mrs. W certainly felt that Sam was drinking probably 2, even 3 times more than normal. They were certainly letting him out an awful lot. He could just get to the night without urinating, but he was asking to go out earlier than normal. So those are my history. And I don't know, what do you think, guys? What's going through your mind right now? What do you think? I hope your mind's getting the same as me, that we've got a dog who probably or certainly could well have polyuria and polydipsia. We've got a dog who certainly has increased his appetite in it. So polyuria, polydipsia, polyphagia, you're thinking diabetes, certainly is a distinct diabetes mellitus, distinct possibility. If it was a cat, we'd be thinking, must be hypothyroid, could well be hypothyroid or diabetic. So why has he stopped eating? What's going wrong now? And if he started to vomit, have we got 2 problems? Has he got pancreatitis? Is he not actually PUPD at all? But obviously the question is, well, could he be ketotic or something like that? So those are my initial thoughts. So what did I find on physical examination? Well, actually, Sam was really pretty weak. He was dull. And as I got to know him, when we made him better, he was a really lovely, lively, happy chap, but he was very dull. Wasn't collapsed, but he certainly seemed very tired. I thought he had a slightly higher than normal heart rate, certainly considering that he looked very dull. I thought he was tachycardic. He had an increased respiratory rate, not markedly so. His breathing was a little shallow, but there was no abnormal sound to his cardiopulmonary auscultation. Look at his mucous membranes. He certainly wasn't pale, but I did think his oral mucous membranes were tacky, and his eyes were slightly sunken back. That's my subjective opinion. And interestingly, I went through the referring vet's notes. And I noticed he'd actually lost 1 kilo in weight. And obviously, he's not a large dog. He'd had a vaccination 3 months previously. So I thought all these were significant findings. But abdominal palpation, there was no abnormal lumps, bumps. He didn't seem to have abnormal pain. I was able to let the intestines gently slip through my fingers. His kidneys felt normal. So the left one was easily palpable. So those are my physical findings. So for my examination, I've got a problem list of him being very dull, lethargic, and possibly dehydrated. So question is, what would you like to do next? Obviously, I can't have any sort of questions as we're coming in. So I hope if you're on the last webinar, the answer you're all screaming at me down the country is, I'm going to make a problem list. And for some reason, my slides won't move on. So here we are. So I made a problem list. Okay. And what I've done as well, just for time and convenience tonight, I've also made my little very big group differential diagnosis, just to show you that this doesn't need to be really detailed. Now, so the reported, I put PPD, his increased water intake and increased urination. And we'll talk about it a little bit more this evening. But again, as we went last time, the way I look at PUPD, there's lots of different ways you could do differential lists for PUPD. I group mine into, it could have an endocrine cause or it could have a non-endocrine cause. And so there's my very big group differential diagnoses. We'll break those down as the evening goes on. If he's got vomiting, this is the same as we were taught at vet school. I consider there could be gastric causes. There could be an intestinal cause, so obstruction, inflammation, neoplasia, whatever it might be. It could be a metabolic cause, renal failure, liver disease, diabetic ketoacidosis, pyometra. So it could be some of those things. Well, you have to technically include central causes as well, although I think if there's anyone with a neurological focus in the audience, I think you will agree with me that there are very few CNS diseases that do cause vomiting, but it has to be on a very low down the list on our differentials. So gastric, intestinal, metabolic are my group differentials for vomiting. Now, weakness and lethargy, well, it could be almost anything. Okay. And again, I would group these as to metabolic diseases, very similar to ones we've had before. It could be endocrine, infectious disease. So weak and lethargy, you could have, obviously could be a significant UTI. If you've got pyelonephritis, you can have really abnormal CNS function and feel really fairly rotten. Could be a sort of tick-borne infection, potentially. So maybe even a sort of a bacterial meningitis is, I suppose, on the list here as well, potentially. So We can have neoplastic disease and we can have neurological disease. So very big, broad differentials. And I've got here, one I actually list off is appetite change. Again, so that could be a lot of different things, but generally what makes you gain your appetite, is something like diabetes, hypothyroidism, or endocrine disease, and so obviously occasionally you see that with neoplasia. And lastly, dehydration. And I think what I put here, if you're just wanting to, lots and lots of things could cause dehydration. So let's just make it simple. It could be functional. Can Sam actually get to his water bowl and can he drink, or has he not got any water? Is there a problem with that? Or is actually there's an underlying metabolic reason that he's actually losing more water than he's able to actually drink? So that's my sort of problem list and my sort of group differentials. Now, you might also be slightly surprised at the order, because I said if you go back to the diagram, we ought to prioritize these lists. And actually, obviously, being that weak and lethargic and potentially dehydrated is probably more clinically important than the history of him possibly being PUPD. The reason I put them this way around, though, is that I've already said my inkling is that diabetes and potentially ketosis would explain everything at this stage. So I put it at the top because it was my priorities to what I wanted to rule in or rule out. Okay. So what can we do about this? Well, what tests can we do? Well, we can do serum biochemistry, and we do a hematology, and we'll come on to those. But actually, I can answer my major worry most quickly by getting a urine sample and seeing, is there evidence of glucosuria? Yes, no. Is there evidence of a urinary tract infection? Yes, no. Is there evidence of ketosis? Yes, no. Quick, simple, not an expensive thing to do. So for me, the first step I would suggest we move forward to this would be to do a urine analysis if we can get a urine sample from him fairly easily. We could run a biochem, and we will come on to that. It's going to take time to run that, and I want to just get an answer fairly quickly. So here we are. These are Sam's results. And what we're going to ask the urine test, what are we going to ask the urine test? What I want to know is, has he got glucosuria? Yes, no. Has he got ketosis? Yes, no. Is there an indication of a UTI? Yes, no. And the answer to all these things is yes, yes, and yes. Okay. So we've got marked glucosuria. We've got ketones. So he must be ketotic. And we've got evidence of proteinuria and white blood cells. Now, he's a dog, so I'm happy to reasonably trust the little purple square on our dipsticks. Just as a side, you're probably aware, but cat urine very commonly gives you a false positive on the leukocyte esterase. So if you get, I ignore what the white blood cell count is on a dipstick on cats all the time. And cats will always rely on a microscopy to tell me if there's evidence of white cells. And we'll do microscopy anyway. And so we spin the sediment down, and we can actually see red cells and white cells. They're degenerate neutrophils, and we can see some rods. So Sam bless him, has definitely got a urinary tract infection. And at the moment, until proven otherwise, I'm diagnosing him to have diabetic ketoacidosis with one simple, let me say, charge for dipstick, potentially a couple of pounds to diagnose this. But just as a thing, his urine-specific gravity is technically normal. How do we explain that? Well, it's not normal. What we got here is a falsely elevated USG. Glucose, when it's dissolved, changes the fractile property of the urine. So if you ever look at a diabetic dog's urine, it always looks really clear and actually not very concentrated, but USG will normally come up often within normal range, as Sam's did here. So that's a false level. If you actually measured his urine osmolarity, you'd find it was abnormal. Okay, so that's why the USG is not accurate in his particular case now. So, having said that, I don't know if that's the only thing he's got. And we need to know now whether other complications, because patients who are dehydrating ketotic, certainly human meds, one of the biggest worries, you develop acute renal failure and renal complications. How's his liver doing? Have we got evidence of liver compromise? Because the liver is working really hard, creating these ketones. So a serum biochemistry is going to be useful to hopefully confirm he's diabetic. I think it's you can have primary glucosuria, which it's those patients have normal glucose in the serum and glucose in the urine excessively, but they don't become ketotic. So it's almost impossible to have that. So a biochemistry in this case is going to be useful to have I got anything else wrong, particularly if we've got anything else wrong with their renal function. But my biggest worry now is what is electrolytes doing? Because these patients can go very quickly hypokalemic, and we need to be really monitoring for that. So going to run a biochemistry to answer those questions. Again, using a problem-oriented approach, I know what might be wrong. Is it wrong, or is he actually okay? So here we've got Sam's serum biochemistry. And also, just further supportive as he's slightly dehydrated. So if you look at his total protein, it's up, his albumin is up. So those would be consistent potentially with him being dehydrated. Obviously, a high CBC. I actually haven't got his CBC, I don't think here, but he had I think remember his PCV was about 52 to 54%. So not technically abnormal, but certainly abnormal for a 9-year-old miniature snout. So we'd expect the PCV to probably be between high 30s, maybe low 40s. Does he have evidence of renal disease? Well, he's got high his high urea, high urea, double normal, but his creatinine is actually normal. So what we've got here is evidence of a pre-renal azotemia, okay, which is very common. The most common cause of that is dehydration, where because the kidneys reabsorb more urea than you'd normally expect in the particular proximal tubule, and that then creates this, with the dehydration causing some volume contraction, causes high urea, but because creatinine is freely filtered, that still gets excreted at the normal rate. So he doesn't have kidney failure. That looks like a pre-renal problem. Glucose is up, as we'd expect. His cholesterol is up, which would support an endocrinopathy, but he doesn't have evidence of biliary disease. His ALT and ALT phos, well, his again, we'll talk about more of this on the mentorship program actually in the October session. But ALT is 3 times normal. Now, I actually am not too worried about that, because my hypothesis was his liver's working hard because it's breaking down those free fatty acids and creating ketones. So actually, an ALT of 190 was pretty much where my mind was saying it would probably be reasonable to expect it to be. ALK phos being high, that's certainly 5 times normal. That is higher than you'd expect, obviously, but that's consistent with an endocrinopathy and a stress response. Remember that dogs have this unique cortisol-induced isomer of ALK phos. So any patient that's sick is like to have elevation ALK phos, and elevation in this sort of range would be consistent with a dog with diabetic ketoacidosis. So I'm not surprised by that result, and I'm not now jumping up and down thinking I've got to go and get biliary imaging and liver biopsies or anything like that. So that's how I interpreted this. Moving on, electrolytes. So sodium, high-ish, normal, so potentially consists of dehydration. But potassium at 3.2, that's low, and that actually worries me, because think about what happens when you're acidotic. The potassium is intracellular and the hydrogen ions are extracellular. So one of the body's responses to that is to exchange hydrogen for potassium, and it's put hydrogen intracellular and the potassium become extracellular. And you then excrete that through the urine to maintain electron neutrality. So if the potassium is 3.2 now, and we're going to start giving insulin, one of the things insulin does is it picks potassium up and it drives it back intracellularly. So we've got a patient who, if we start giving insulin to correct his diabetes, his potassium is like to drop like a stone. So we already know we've got to watch this very, very carefully. His CPLI is negative, just I think it's a pancreatitis isn't there. The chloride's the other interesting one, and I probably could do a seminar on hyper and hypochloridemia and acidosis, but it is known that chloride can actually drop in patients with DKA, and it's probably a direct effect actually of the organic acids, causing a compensatory response, and low chloride actually creates a metabolic alkalosis. So this may well be an attempt by the body to compensate. The mechanism is not completely understood to my knowledge anyway, but it indicates we've got a mixed acid-base imbalance in SAM. Now, what I notice here, I don't actually have a blood gas analysis, because at the time, this is actually quite a long case, and I presented it. I didn't have blood gas analyzer that was working that night, typically, but I deliberately presented SAM because I want to show you that if you don't have one in practice, these patients can still be managed. So, in summary, what we've got: patient who's hypoglycemic, he's got ketosis. I put mild hypokalemic because I'm worried that actually his total body potassium is probably pretty depleted, and so we may see the effect of that when given insulin. And we've got hypochloremia, which would be acidosis induced. He's dehydrated and he's got a UTI, and I suspect what happened is he was diabetic, he developed the UTI, and that's what pushed him over to be ketotic. So what are we going to do about him? Well, what are our aims in treating? What will kill Sam if we don't get him right is the ketosis, the acidosis that responds from that, and then the dehydration. And if you don't treat ketosis, then it's a terminal disease. But it's so treatable. Okay, so we need to stop the ketogenesis, which is actually remarkably easy. We need to help restore his circulating volume, because if we restore his circulating volume, his kidneys will sort out any acid-base imbalance for us really quite nicely. So again, although having a blood gas analyzer does really help to fine-tune some of these patients, the key is getting the dehydration corrected. And we also, I think, because I thought the UTI was the trigger for the ketosis, we need to identify what it is and treat it as accurately as we possibly can. So how do you stop ketogenesis? Well, to know how to stop ketogenesis, you need to understand what happens in normal metabolism. And hopefully in you and I right now is the presence of insulin activates lipoprotein lipase, which, so the bit on the left-hand side of the slide here, drives free fatty acids into adipose tissue. And although hormone-sensitive lipase, which breaks down adipose tissue to release free fatty acids, is pretty much switched off in the presence of insulin. Okay, there's always a little bit trickling through. We always get some activation and fatty acids going into the so Krebs, and actually make a little bit of ketones all the time. But that's the situation in a patient who's got some level of insulin in the body. And don't forget, in all patients, you and I, all our dogs and cats who are not diabetic, do have a background level of insulin, a little bit there. It doesn't go on off completely. It goes up, but down to low level. So that's what keeps this in equilibrium. In a patient who is diabetic, however, the problem is the absence of insulin. So lipoprotein lipase is not activated. And more importantly, it's HSL in green here on the left-hand side. That stands for hormone-sensitive lipase. Hormone-sensitive lipase is switched on, and actually it's amplified by the other stress hormones that we have, so cortisol and things running around. And what that does is that creates a marked mobilization of free fatty acids from adipose tissue, which all goes to the liver. And hormone-sensitive lipase also activates fatty acid acyl-CoA, an acetyltransferase, which drives those fatty acids into the hepatocytes. And then the hepatocytes go, whoa, what are we going to do? And they make ketones in response. So the lack of insulin is actually what drives the formation of ketones through this pathway. So the simple way of switching off ketosis is to reintroduce insulin into the system. And that will damp down and hopefully eventually switch off hormone-sensitive lipase, reactivates the lipoprotein lipase, and drive those fatty acids back into adipose tissue. So what are we going to do? We're going to correct his dehydration, and we're going to get some insulin on board. So I estimated him to be, and this is standard stuff, you do this every day, I thought he was around 10% dehydrated. So the aim we're going to do is we want to replace 50% of that in 6 hours. So that's just simple. And then the remaining 50% in the following 24, plus think about his maintenance treatment. So it's 2 mils per kilo per day, plus whatever alpha. So I was actually going to give him 3 mils per kilo per day. I think we decided just as a maintenance. What fluid should you use? And well, I think it's one of those debates, really. It depends on, you could get into the argument, what's this chloride? And so normal saline is an excellent choice because it will help restore circulating volume. Hartmann's, slightly different, obviously, electrolyte solutions. It does have lactate as a bicarbonate precursor, and that's safe to give in patient DKA. How much of that lactate would be converted to bicarb to help damp down the acidosis is debatable when the liver's working as hard as it is, but either would be good choices. The key thing we've got to have, you've got to supplement the potassium. And this is where managing DKA, what I'm about to say now, may make the difference whether you think you can manage them safely in-house or whether you want to refer to an out-of-hours centre or a specialist centre. Because you need to be able to measure potassium probably no less than every 6 hours for the first 2 to 3 days in these patients, because the potassium can plummet really very quickly as soon as you give insulin. Okay, so if you can only measure potassium once or maybe twice a day, it's risky if you can't really be on top of what's going on. Okay, so that's what we're going to do for his fluids. In terms of insulin, what you have to use here, can insulin, Prozinc, or PZI is not going to be enough. We have to give neutral insulin, so there's just literally insulin in a bottle, sometimes called soluble insulin, and you give it intravenously. So, and the dose is you give 0.1 unit per kilo, and you can equivalent of that every hour. So setting up a CRI is wonderful. Again, a really practical thing that you could do in practice is just give this little bolus once every hour and just get a little spot blood glucose immediately beforehand, it won't change for the first probably 4 to 6 hours, sometimes even longer. But you should then start to see that glucose dropping. And as soon as you start seeing the glucose dropping, you know the insulin is working. And that means you know that the ketosis will be starting to be switched off. The ketogenesis will be switched off. Okay. General rule of thumb, though, is because you want to know exactly what your electrolytes are, I would give the fluid therapy for 4 to 6 hours first, start rehydration, and then give the insulin, because that's going to mean you're probably going to have a more effective insulin response as well. Okay. So I in Sam gave him 0.1 units per kilo IV once an hour, and did actually, I think that for I think it's needed 2 days. We'll come on to it. So what about can insulin? You can't obviously keep giving solid insulin, because solid insulin will last for a half-life about an hour. Okay. So when you get your blood glucose into the low teens, you can start giving can insulin, and then I would start at half unit per kilo, but keep going with the soluble until we've got it down to somewhere period normally can see that there's a response during the day. Now, just in case any of you ask, or some of you read some things recently, one thing that's becoming quite a common theme with ECC specialists is to actually give dextrose at the same time. I just thought I'd cover this quickly. Seems completely bonkers. You've got a diabetic dog giving dextrose too. In human medicine, it's been proven to be really successful, and a lot of ECC specialists in the UK and Europe now will do this too in our profession. If you give a very low dose dextrose, it means that you're not going to have, you ameliorate the risk of having a sudden drop in glucose with the insulin. So it means you can give the soluble for longer, which means you might get a more rapid response to the ketosis. I have to be honest, I've read the literature. I know what we're supposed to do. I'm not sure. I'm yet to be convinced that it makes a massive difference, in my humble opinion. But I'm well aware that I'm probably going against the grain of what the current literature says. So I just thought I'd put it there. So that's basically our treatment. Okay, what else do we need to do? He'll be feeling sick, so we need to give him some antiemetics. So serenia certainly will stop them being sick, but it stops feeling nauseous is the debate. So you can use metoclopramide or ondansetron instead or as well. We need to get him eating. Okay, we need to get some calories on board if we possibly can. So just even a recovery diet at this stage would be enough, just to try to get some calories coming on board. And we need to get a urine sample, get whatever that infection was. In him, it was I think it was an E. coli from memory, and we then treat according to culture and sensitivity, because we need to get it under control, because that will be causing insulin resistance, which is going to make things worse. So actually, DKA patients, the basics are fairly straightforward. And if you can measure your electrolytes and monitor them well, you can manage these patients in practice. Okay. The fine tuning is what matters. So some patients need more monitoring than others. The key thing is, though, use fluids. Soluble insulin is absolutely essential in those first 2 to 3 days. And you must be able to keep watching that potassium, okay, because that will drop really quickly. So, how did Sid do? Sam, sorry, why have I got Sid there? I do apologize. The second dog in my trial was called Sid. He did really, really well. And we got him right, and he transitioned on candidates sole treatment after 3 days. And the reason he was such an important patient to me was that he went on to get gene therapy. I was doing I still have, although it stopped with COVID, a clinical trial where we're getting the liver in diabetic patients to make human insulin, using a technique called AAV8 gene therapy. And what we managed to do with him, we actually got him to produce his own human insulin, which reduced his own injection requirement by 50%. And he was the first dog, we think, in the world. I haven't published this paper yet. I've got to get on and do that. But the first one to ever receive that treatment. So that's why he was such an important patient to me. So I hope that's helpful for you with in what we're going to do. So now, just very quickly, I think we did this briefly last time, but I thought I'd mention it. Oh, sorry, I've gone back on. Is what can we do? I've got a chat box here I'm trying to close. I can't say. What can cause patients who are diabetic to be unstable? And very briefly, I'll do this hopefully in about a minute, is if you're a patient who you think you've done everything but isn't responding well, I break these into owner issues and clinical issues. Need to review how there is handling insulin. Remember, insulin is a delicate molecule. If you shake it hard, it'll break. So you've got to roll it gently and keep it just in the same place in the fridge, not at the back at the top shelf because it can freeze there. The owners maybe change where you're injecting and make sure the owners are feeding what you've instructed them to feed. If you've ruled that out, fundamentally for me, there are 3 possibly four main things, clinical issues. Patient is not responding to insulin properly, rule out an infection and particularly rule out a UTI. Okay, infections cause insulin resistance. Second thing, go looking for a concurrent endocrinopathy. We talked last time about Honey, the Labrador with Cushing, so rule out a concurrent endocrinopathy. Cats, you can rule out acromegaly. We'll talk about that in a second. But look for other causes. And also go looking for potential causes of neoplasia. So cancer can cause insulin resistance. Fourth thing I put in here, I put inflammation. I remember a lovely Weimaraner I had when my first job in practice. I qualified about 9 months. I already knew I liked diabetes, and I think I mentioned this little dog who was diabetic, Métis diabetic. I got her spayed. I didn't do the surgery, I promise, and came off for insulin, but then became diabetic again. And what we found was that the surgeon who'd done the surgery actually left a swab at the ovarian pedicle. Removal of that, and we actually managed to get the diabetes under control. So chronic inflammation somewhere can also cause insulin resistance. Now, I thought I'd spend just a little sort of instruction on feline diabetes because it's something we haven't talked about. It's much more common than people think. There's I think the Vet Compass team at the RVC are brilliant and come out with some really great papers. And actually, they said that 1 in 200 cats in the UK potentially have diabetes, which is really interesting. And that was a large-scale study. There's some breeds that get it more common than others, which again suggests there's definitely genetic sort of risks of causes potentially in feline diabetes, just like we think there's genetic risks in the dog. But the key thing in cats is cats are not like dogs. In dogs, we have insulin deficiency caused by failure of the beta islets. And that's probably not immune mediated, so that whether they're true type 1s like in human teenagers is another debate. The reason cats are different is cats get type 2. So what happens is there's something in the cat's body that causes insulin resistance. Most commonly that's going to be obesity, cats being overweight, potentially some sort of long-term stress. But as we'll come on to talk about, acromegaly, so excess amounts of growth hormone, is probably more common than we thought it used to be. And what happens is you get a vicious circle that actually, if you have hyperglycemia, the little beta islet, which is the slide, the lovely purple dots in the top right here, they make more and more insulin to try to overcome that hyperglycemia. But when you make insulin, you release a molecule called amylin, which when meet together will form amyloid. So the cell, the purple diagram, the microelectron, the micrograph at the bottom here is a beta islet that's full of amyloid because it's from a cat that had diabetes. And amyloid just stops the beta islet from working. So what happens is, well, they have hyperfunction to start with, the beta islet then downregulates, and if you still don't correct it, will eventually fail. So this is why if we can get on top of feline diabetes before the beta islets completely fail, there's a chance of rescuing them. And what I want to just do, because it's an endocrinology talk, there's a really great study by Steve Neeson, who's an absolutely brilliant endocrinologist. Obviously, I think he's a special professor at the RVC, published a paper 7 years ago where they screened 1,200 cats in the UK for acromegaly. And what they found was around about a quarter of these cats actually were positive for acromegaly. What's even more scary, though, and this is done at the RVC, don't forget, so good clinicians, only a quarter of those patients was there any clinical suspicion of acromegaly. So they didn't look huge, they weren't enormous cats. So afterwards, what I now do in all newly diagnosed feline diabetics is I will screen for acromegaly, which is really simple. You measure a thing called IGF-1, insulin-like growth factor 1, and anything over 1,000 is diagnostic of acromegaly. Okay, and in most of these cats, almost all of them, it's a small pituitary mass that is causing the disease. So I just thought I'd mention that because it's something that you probably some of you may be doing, but many of you may not be. But if in my workup for feline diabetes, I now do an IGF-1 as a routine test. So how do I keep feline diabetics? They do present like dogs. They're generally middle-aged to older cats. Some studies show more males than females, which again is probably because of the acromegaly, because that's more common and they have PUPD, weight loss, and changes in behavior. I treat my cats in the same way as dogs. And I know the starting dose for Canich is recommended 0.25. I have to, as I've normally found, I will start higher. I've normally start about 0.4 units per kilo. I use Canich over Prozinc out of habit. I don't think it's necessarily better. And the other thing that's really, really key is you've got to get them on a diabetic diet. High protein diets and low carbohydrate diets make a big, big difference to diabetic cats and are the key to help getting them into remission. So how do you know get into remission? Well, actually, remission rates are somewhere between 15 and 50%. So it really is worth having a go for this. Really explain to owners who might go hypo. But if they do go hypo, it means you can keep them on the diet and take them off the insulin. And the vast majority of those cats will actually go on and do really, really well. Okay. So it's worth really driving diabetic cats if you possibly can. Really get the control under way if possible, but do give owners instruction what to do if they're hypo. Okay, so honey or glycostop or something on the glucostop on the gums, and don't give him more insulin until I've spoken to you. Okay, so I think that's what I want to talk about with diabetics. I'm just going to look up here. Have I got any questions? Does anyone have any questions?
Well, we did just have a couple of quick questions. The first one would be, if you know a cat is acromegalic from doing the test, how would it change your approach in terms of treatment?
Okay, it's a really good question. Actually, it's going to be really difficult to get the cat under control if you don't treat the acromegaly. So there's a very famous cat at Cambridge Vet School that came in on 80 units of insulin twice a day. He's acromegalic, and he still was diabetic. Okay, so that's how I say the insulin resistance you have is massive. The treatment is depends where you go. If you went to Cambridge or Southfields, they will recommend radiotherapy. And actually, radiotherapy, in my experience, I've radiated nearly a dozen acromegalic cats, and it works really, really well. There are some centers, Utrecht in Holland would recommend hypophysectomy and actually remove the mass. And I think the RVC are now starting to do that. Personally, I do radiotherapy. Our cat, Moss, with 80 units, when he had his pituitary radiated, became non-diabetic for 2 years completely. And then 2 years later relapsed, and he was managed on 8 units. Okay, so radiotherapy, you've got to treat them if you possibly can.
Probably save the money in terms of insulin.
I still don't know how the heck he got to 80 units. It's like, what are you doing? I was like, going through a bottle every couple of days, but it is over a long time. So yes, you do need to treat them.
Brilliant. And then just one other quick question. Do you, from your perspective, a lot of vets who are coming tonight and watching this back, they're probably keen to know, do you think blood gas analysis is vital when managing DKA cases?
Yeah, look, it's a really good question, Lydia. I don't think it's vital, but it's extremely helpful. Okay, because if you can fine tune whether you want to give bicarb, you fine tune the fluid therapy, you can monitor the chloride more easily, and it just gives you a better handle of exactly what's going on. But as I illustrated with Sam, it's not essential. So please don't feel that you can't manage them. The key one is you've got to be able to measure the potassium. Okay, and you've got to measure that at the bedside or the cage side. Okay. Or at least have the lab just down the corridor that you could run to at any time of day or night. So it's not essential. If you have got blood gas there, you want to be doing arterial samples, okay? Because that's the best way you're going to know truly what's going with acid base and look at the anion gap. And so it's a nice thing to have, but it's not truly essential.
Brilliant. That's great. If anyone has any other questions for Rob, please pop them in the chat box. But otherwise, I'll let you go, Rob. Let you carry on, and I'll do with it case 2. Thanks.
Well, hopefully this is one we can get through a little more easily. So this is a fascinating little case. A little Shih Tzu called Bobby, and he had been in the owner's possession since a puppy at 8 weeks of age, and he got referred by the referring vet because they couldn't manage and couldn't work out why he's polydipsic. And when I spoke to him, I realized why, because he was drinking hugely. Remember we talked about last month, normal water intake of dog is between 20 and 40 mils per kilo per day. The technical definition of PUPD or polydipsia, is more than 100 mils per kilo per day, but over 80 is probably abnormal. Little Bobby was drinking 434 mils per kilo per day, which is enormous. And it does bring to mind a boxer dog I saw once who has the same disease as me, eventually diagnosed Bobby to have, who was so thirsty he would urinate and try to drink the urine at the same time. So some of this dog, Bobby, was drinking loads. And obviously that was pretty difficult for them to manage because they hadn't been able to do his toilet training because he was just urinating all the time. So this was a real problem for the owners. They had vaccinated him. He has wormed up to date. He'd not traveled. And the referring vet had quite simply thought, well, maybe it was a urinary tract infection with a sort of causing a kidney problem. So giving him some trimethoprim sulfur, hadn't worked. And then he thought, God, this volume of urine, water, it must be diabetes insipidus. So they tried giving him some ocular DDAVP, which is the analog of antidiuretic hormone. And they'd given it intraocularly and done that for another week for referral, but nothing had changed. So they'd sent Bobby in. So what are we going to do with Bobby? Oh, sorry. Let's see if I can. On examination, so 3 liters and a 7 kilo, nearly 7 kilo puppy. That's a lot of water. He was lovely. He was very bright. He was in very good body condition. Wasn't underweight, and I could fundamentally find nothing wrong with him. Abdominal palpation was normal. His cardiopulmonary auscultation was normal. His rectal temperature was normal. I did a full neuro exam as much as I can as a medic, and I couldn't find. So I was sitting here. What was I going to do? So I challenge you. What are you going to do if you were me or Bobby presented to you? I think we'd all recognize this is not a normal situation. So I hope you're all screaming at me, I'm going to make a problem list. So let's make a problem list. I'm fair to say it's marked polydipsia, marked polyuria, and has been present since he was young. And I think the historical context here is important because it implies it could be a congenital issue. It might be something that's just acquired very early in life, but it could be something he's actually been born with, which brings in a different list. So let's just review what can make you PUPD. Showed this little list if you weren't on the meeting last time. I split my PUPD patients into patients who have endocrine disease and those who have non-endocrine disease. And these are the list of diseases I'm thinking of. And I will write this list out. And so if you come on the mentorship program, we will do a big session on PUPD, and we'll obviously have this material available for you. So in my shorthand, HCC is Cushing's. Remember honey from last month? So now, Cushing's disease in a puppy, I've never heard of that. Okay, I'm not saying it doesn't happen, but it's pretty impossible. He was a cat. Hypothyroidism would obviously be there. Hypothyroid puppy. I've been. It's a case report. Remember hyperparathyroid, Bentley, the Irosetic we talked about last time. That causes hypercalcemia, and that then leads to marked PUPD. He can have DM, diabetes mellitus. Now, juvenile diabetes mellitus has been described in the dog, but it's actually been more described in Labradors than anything else, and it generally starts at about a year of age. So it could be he's a congenital diabetic mellitus patient. We can't rule it in or rule it out, but we need to do some testing to test. Or DI, he could have diabetes insipidus. And certainly the volume he was drinking was making you think that was a distinct possibility. And then on the non-endo list, he could have, has he got renal dysplasia? Has he got no kidney? Something really weird with his kidney function. Unlikely he's got many of these other things, but could have a kidney infection. He could have been born with something. Or has he got something, a congenital abnormality of his liver, or a renal tubular disease, like a renal tubular acidosis or something like that? So looking at his age and his signalment, I was pretty certain that we could probably rule quite a few of these out. So the ones in light blue now, the ones I was thinking are less likely than anything else. So what I want to do is there's my differential list. I'm going to provocatively investigate this by testing specifically for these things. So diabetes insipidus, we're going to get some indications from a urine test. We can't definitively diagnose on urine, but get a good idea. We're going to do a biochemistry to look at the evidence of renal failure. We're going to look at any evidence in the urine sample of renal infection. And we're going to use bloods to look for hepatic disease. And we're going to do the urine analysis to look for renal tubular disease. So what's the most sensible way forward? What's the cheapest, quickest way forward? Let's get a urine sample. So here's Bobby's urine sample, which you could say was quite boring, but with one notable exception. So no evidence of diabetes mellitus. We've got no ketones. There's no evidence of UTI. But that specific gravity is super, super, super low. That's almost pure water. I think pure water is 1.000. Now that's really important because he has got hyposthenuric urine by distinct definition. But that suggests that his kidney tubules are working normally. Think about what you have in a patient who's got chronic renal failure. They have isostheuric urine. Why? Because the kidney tubules can't reconstruct urine. So let's go back to your first year or maybe second year physiology. Think about what happens in the proximal tubule. The proximal reabsorbs amino acids, reabsorbs bicarbonate, reabsorbs glucose, and does a lot of that sort of action. But the loop of Henle sucks out as much of the urea and sodium as it can to make that very hypermetonic renal medulla. So by the time the glomerular filtrate reaches back to the distal tubule, and the distal tubule helps that as well, you've got almost pure water. And it's that then is what enables, when you have a very slight change in the absorbency of the collecting ducts, we can then reabsorb that water and have really fine control of our water balance. So if you've got a urine specific gravity that is this low, it suggests the tubules are actually working up to the collecting duct. Okay. And it's something I used to get, it's very common clinical advice, actually not so much with EDS. Maybe but certainly in my previous life at DWR, we would get a lot of advice calls going, "Hi, Robert, I think I've got a dog that's got diabetes insipidus." My first question would be, what's the specific gravity? And if you said to me it's 10.06 or above, I'd go, I don't think so. Or it's less likely, because that would suggest that there's a reduced tubular function. If you've got specific gravity this low, it's just the tubers are working fine, but something's preventing the reabsorption of that clean water. Okay, I hope that makes sense. So I'm instantly now suspicious that diabetes insipidus is a distinct possibility with Bobby, and it matches the volume of water he's potentially drinking. But what about, is there anything else? I said we need to look at evidence of renal dysfunction on bloods. Have we got evidence of hepatic dysfunction? No, we've got his pH is normal, the urinary pH. So this is by definition, can't be a renal tubular acidosis, because those patients have a markedly abnormally acidic urine. There's no evidence of proteinuria, so it's unlikely to be a glomerular nephropathy or a tubular nephropathy. And we've got no evidence here of there being overt UTI. I accept it's possible, very occasionally, we said this before, that to get a UTI that you don't get much evidence of in urine, but I think it's very much less likely. So I did my biochemistry to see if I have any evidence of anything else going on, particularly hepatopathies. And you can see that, so the bold doesn't come out very nicely here, but this is actually really fairly unremarkable. ALT, AST, hepatocellular markers are unremarkable. Alk phos is actually normal, which I was expecting it to be slightly high because he's still growing, like just about, maybe his growth plates are just starting to close. Alk phos is often up, obviously, in young patients. His calcium is slightly high, which I put down to potentially being his age. Slight discordancy there between alk phos and the calcium, but I was happy to run with that. And the phosphate's up again. That fits with age, and there's still being bone growth. Interestingly, we've got a very same pattern here we had with Sam before. We've got a normal creatinine and an elevated urine. In fact, they almost exactly the same numbers, aren't they? We've got prerenal azotemia. Why have we got prerenal azotemia? Is because actually little Bobby physically can't drink enough water, so he's very slightly dehydrated. So otherwise, though, there's no evidence of any metabolic diseases here at all. So what else do we need to do? Have I ruled out other liver function? Because don't forget, the biochemistry gives a lot of idea of renal function, it's liver function, albumin production, cholesterol production, bilirubin production, urea production. But to be absolutely certain his liver function normal, a bile acid stim is a really good thing to do, because it actually tests true function. So we did a stim just with some AD. You don't need to put oil on food just on that, just AD is more than fatty enough. And you see his bile acids are completely normal. So I'm happy he doesn't have a shunt. He doesn't have evidence of hepatic, of a functional thing. And then I'm presenting. I said I'd do it warts and all. I did decide to do an ACTH stim. I'd never seen a case report or anything of a dog of his age with Cushing's, but because the way we definitively diagnose a diabetic insipidus patient is water deprivation test. And when you've got a dog drinking this much water, water deprivation test is actually dangerous. You can dehydrate them to potentially fatal level. I want to be absolutely certain there's no other diseases. I've reflected on Bobby when I was preparing these webinars. Would I do that again? And I think we come on to his imaging in a second. The fact there was no evidence of adrenal enlargement in his imaging, and it's almost unheard of to have Cushing's, I wouldn't criticize you if you didn't do that step. And I don't think it was necessarily wrong to do it, but was it unnecessary? Oh, it's sitting on the edge of whether it was necessary or not. So sorry, didn't we do it? So low dose dex, low dose dex, because obviously said last time it's more accurate in patients who are otherwise fairly well. So I was happy to trust that there's no evidence of it being a problem. So what are we going to do? Let's go back to our differential list. We've now pretty much ruled out everything. And the only question mark I've got is, could he have a grumbling pyelonephritis we're not picking up in some way? Okay, I think it's highly unlikely. But remember, why do you get PPD in patients with pyelonephritis? Is because the inflammation affects the way that ADH binds to V2 receptors in the collecting duct. It actually prevents the branding. So if you have a patient who has got a pyelonephritis, what they get is the secondary acquired partial nephrogenic diabetes insipidus. So we need to be absolutely certain that the bobby doesn't have any evidence of an infection. And when you're producing urine that's that dilute, you're at risk of a UTI. Although I think it's fair to say if you're weeing that much, you're probably going to wash any bacteria off anywhere. So I just went back around the coop of could he possibly have a renal infection? So undertaker's imaging, and this is actually his ultrasound picture. And as you can see, the two little, I apologize, I don't have a cursor. I don't think you can, I'm not sure you can see this, but there's two little crosses in the middle here. That is evidence that that's his renal pelvis. So he's got pyelactasia. Well, you could say, not surprising, Rob, because he's drinking so much. And I think that's probably true. But he had, other than that, there was no evidence of abnormality in his kidneys, no evidence of anything else abnormal. So still I don't have a medullary rim sign. I've not got hyperechogenicity. So no real evidence support there being an infection. But now, this was quite a long time ago, this patient. So this was pre our awareness of antibiotic stewardship. I did decide, because I thought he was a small dog, doing a pilocentesis would be the ideal thing to do, but here was a very small area of enlargement, that renal medulla, renal pelvis. And although I was working at the time with unbelievably good images, I thought it was unfair for them to stick that. And also, if ever you have gone in surgically in a patient, you've done a final aspirate of a kidney, there's a huge hematoma under the capsule. And I was just in the phase of my career, I was really scared of sticking needles in kidneys. I'm probably not so worried about it now. So I decided to give him a urinary tract excreted broad spectrum antibiotic. So I give him potentiated tamoxicillin, comoxiclav. And I think I was really wanting to cover was E. coli. Would I do this now? Was my reflection. I've got to be honest, I don't know if I would. I think that's, I think we've changed our view on throwing antibiotics about. I wouldn't criticize you if he did it, but I think all this evidence on his clin path is telling me he probably doesn't have urinary tract infection. And if he does, it's not the sole cause of everything. So again, just being honest and reflecting on what I would do now. At the time I thought it was right things, I'm now thinking maybe that was a little bit unnecessary. So it didn't make a difference though. When I gave him the comoxiclav, he still drank that much. So what we've done is we've used problem-orientated medicine to reach the point where, by definition, at the moment, the thing I've got to rule out, he's got diabetes insipidus. So how do you definitively diagnose that? Well, what we've got to do is we've got to do a water deprivation test. Why do we need to do that? Well, when you've got diabetes insipidus, there are two main forms. You can have central diabetes insipidus, as shown on the left here, where you don't have ADH formed in the hypothalamus and the pituitary. Okay, so you don't have antidiuretic hormones, so there's none to release. So the hypothalamus is screaming, I've got to make I'm dehydrated, but the pituitary doesn't respond, and no ADH is formed. So you've lost that positive feedback. That's right, lost the negative feedback. Or you can have nephrogenic diabetes insipidus, which is where the hypothalamus pituitary are able to make antidiuretic hormone, but the kidneys can't respond for some reason. Now, both of these conditions could be congenital or acquired. So you can have central congenital, where there's an anatomical abnormality where you don't have the neurons coming down from hypothalamus into the pituitary to actually make ADH. Or you can have acquired. And I remember a really sad case of a little Labrador puppy when I was in my residency at Cambridge, where the owner was a DIY fanatic. I was refitting a kitchen and managed to drop a cupboard door from a height onto this little puppy's head. Not great. And the owner reported that didn't feel very well, but the puppy started drinking more within about 45 minutes of this accident. And what we found was they'd actually got a fracture of at the base of the skull, which had gone straight up into hypothalamus and actually caused an acquired central DI, which we did actually manage to sort. Likewise, you have nephrogenic. You can have acquired nephrogenic, as I've just said. Any inflammatory lesions in the kidneys cause a partial nephrogenic diabetes insipidus, pyelonephritis. But you can also have congenital nephrogenic DI, where you don't have the V2 receptors in the collecting duct. So you've got oodles and oodles of antidiuretic hormone in the circulation, but there's no receptor site for it to bind to. Okay, so that's how. So we've got to work out what's going on, and a water deprivation test will help us work out if they've got DI. And then we could do provocative testing to work out is it central or nephrogenic. And we need to know the difference because the treatments are very, very different. Okay. So now, water deprivation tests are actually dangerous, okay, because the aim is to dehydrate the patient to 5%. And if you've got a patient who's very polyuric, they can do that very quickly. And if you're not on top of it, they can actually dehydrate to a much more dangerous degree. So what I decided to do in here was I decided to do sort of a modified water deprivation where we gradually reduce the water intake for him at home. So can do it at home, but we did it in the hospital. So where you go limit 150 mils, 120 mils and down, and you can set this. The aim is to try to get a little bit of concentration at renal medulla and to see where we are. If you've got a patient who's not drinking quite this much, you could just have them in hospital. And I normally start my water depth test at midnight, okay, which is obviously a bit inconvenient for the night team. But why do I do that? It's because probably not in Bobby, but in patients where you sort of more standard diabetic insipidus patients, they tend to reach that 5% dehydration point 6 to 8 hours after you start the depth test, which means just as I'm coming into work, I'm then there on site to be able to do the following up work we're going to do. Whereas if you start the water depth test after you've had a morning surgery and you get things done, you start at 10, they just get to 5% dehydrated at about 6 o'clock at night, which is not what you want. So if possible, my advice would be that you start them at night and then you've got the whole day to do the work as long as you've got night staff, because you must check these patients' weight and urine specific gravity every hour. You've got to get them to urinate and see if what their weight does. If they've got dropped 5% of their weight, you know, got 5% dehydration. And if their urine specific gravity doesn't change, you need to know. So that's what we did. He's a male dog, so he's easy to catheterize. So we placed urinary catheter and got urine specific gravity at the beginning. We emptied his bladder, we weighed him, and then we did that procedure every hour. Empty the bladder, weigh them, and as soon as you get to, and you work out what is 5% of the body weight. So I actually write this on the sheet. If they hit this weight, ring me. Okay. And it took him 6 hours. So it's quite quick. He lost 5% of his body weight, and his specific gravity still hasn't changed. Okay. So really, we've now definitively diagnosed diabetes insipidus. I've put in the slide here, ruled out primary polydipsia. Now, there's a webinar on its own. Does primary polydipsia exist in dogs? Polydipsia in humans is considered generally to be part of the OCD complex of diseases. And I've only diagnosed one dog I thought was truly primary polydipsia, and it was a border collie. If ever there's a breed that might get OCD, it's border collies, I think, isn't it? So I digress. So for me, the fact he gets 5%, that's an abnormal physiology. We've ruled out everything else. He has diabetes insipidus. Now, we've then got to work out if it's central nephrogenic. How do we do that? Well, we give an analog of antidiuretic hormone, which is DDAVP. And if you've got central diabetes insipidus, i.e. you're not making ADH, the kidneys are crying out for it. So when you give DDAVP, the kidney will go, gimme, 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 and actually there will be some concentration of the urine. It doesn't go completely to normal necessarily, because in some patients, they don't have that medullary concentration gradient to make truly concentrated urine, but you'd hope to see some movement towards an isocynuria, if nothing else. If you've got nephrogenic diabetes insipidus, it doesn't matter how much DDAVP we give, you're going to continue to dehydrate, okay, because they can't respond. So what we did for Bobby, we do give some water because he can dehydrate. So we gave him maintenance. We carried on the protocol, give it IM, give it intramuscular injection. And what we found was that his USG actually did get to 1020, okay, and he's having some fluids. So what does that tell me? We've made a definitive diagnosis of Bobby of central diabetes insipidus. I didn't do MRI imaging in him. They ran out of money by this point. And I was worried that the DDAVP is not the cheapest medication. So I'm not sure what was, and I don't even MR would have necessarily told me that, whether there was what was the problem, but he had a lack of antidiuretic hormone. So how do you treat it? You just replace the hormone. And there are two ways of doing it. You can, the DDAVP ocular drops is what is often recommended, but my experience that is it's not great because the bottles are glass, so you have to shake them, not squeeze them. And I've actually found the DDAVP tablets to be an awful lot more simple, easy, repeatable, and you give them 3 times a day. And that's what we did with Bobby. And you measure the efficacy of the treatment by, number 1, urine specific gravity, and number 2, have you got the water intake to be normal? And actually, Bobby's water intake went completely back to normal. And I followed him for 6 years, and then the owners moved away. But he remained completely well, no complications whatsoever, completely normal quality of life throughout that period of time. So presenting him, because these patients are really easy. If they're central, they're fairly easy to treat. Nephrogenic ones are much more challenging. And for time, I won't go into it, but what you actually treat those with thiazide diuretics, which sounds completely counterintuitive. And the outcome with true nephrogenic diabetes mellitus patients is actually really quite difficult and not always great. So there we are. I apologize. I've overrun very slightly. Very happy to take any questions. But I hope that what we managed to do over this webinar and the previous one is to help you see problem. Oh, shush, Siri. Problem-oriented medicine. Siri doesn't listen to that. Can really help, can navigate you through complicated cases, but also how we can help you in practice at VVS, and not just necessarily with the medicine cases, but with the other colleagues in the other specialties. By going through this logical process, we can help you take through a case. I really hope I can look forward to working in the future, and thank you very much indeed for all your time and attention. And just think there's a lovely view of, well, anyway, we have great weather here, haven't we? But not today. Certainly in this part of the world where it's been raining all day. So thank you so much, and happy to take your questions if you've got some.
Thank you, Rob. That was brilliant, so informative, really interesting. We've got a question coming in already.
Oh, cool.
So if you don't have the facilities to safely perform a water deprivation test, is it appropriate to trial DDAVP?
So it's a it depends partly, I think, on the owner. Okay, because if the owner is managing the vast amount of water intake the patient has, they've managed it quite well, then the answer is possibly. But you need them to report to you all the time, because if you give the ADAVP and it's central, then the dog should control its own water intake. So it does. Central patients, it's safe. The problem comes is if it's nephrogenic or if they've got UTI as well, because you don't know if they're going to respond properly or not. So I think it's a reasonable thing to do, as long as you explain to the owners that it may or may not work. The other thing, you don't know what dose you've got to give. So advantage of giving a water deprivation first is if you confirm it's definitively central DI, you can ramp the dose up. It's 0.1 to 0.3, I think, micrograms per kilo. So you can start low dose and go up knowing you're fairly safe. If you otherwise, you're not quite sure what to do, but you probably would get an indication if it's central. Yes, you get some reduction in water intake. So not perfect, but I think it's a reasonable way forward. As long as you've gone through all the things beforehand, you know it must be DI.
And I had one question regarding this case. So you kind of reflected that you wouldn't do the antibiotics. Yeah. Would you have gone forward straight to the water deprivation test, or would you have persisted with trying to get a sample from your imager, listen, put them under pressure?
Well, first, guys, I hope this helped. I think all of us reflect on cases, and the thing is not to bash yourself over the head with it, but to try to make it a positive, constructive learning experience. And this is where I modify what I do based on practical experience. Okay, I think firstly it depends on the dog. Bobby was only just under 7 kilos, and yes, I've been lucky enough to work with some probably the world's best imagers. Asking them to stick a needle into that small renal cavity, renal pelvis was a challenge. In a larger dog, I think now with hindsight, I would go for paracentesis if the renal pelvis was reasonably sized, and if my image was happy, and if the platelet count is normal. For God's sake, check your platelet count before you stick needles in kidneys. And if also, before anyone's, the key to sticking a needle in a kidney is do not cross the corticomedullary junction. Okay, you must never, because again, renal anatomy. Remember, there's that huge plexus of veins and the arterioles that runs between the cortex and the medulla. If you stick a needle through there, certainly doing a true cut, oh God, only ever true cut the cortex. I think all the people do this. So be very careful. But if you can come in from the lateral aspect and go in, I would probably try, yes, if the imager said I'm happy to have a go, I would go for paracentesis if possible, Lydia.
But in this case, you would have just gone straight to water deprivation.
Yeah, I think with hindsight now, I'd have gone straight to water dep, because I think the chance of him having UTI is so small. The other thing, I'd talk to the owner if the owner doesn't want to take the risk of a paracentesis, because they do bleed, and then I would happily respect the owner's opinion. If they asked me to lead them, I would make the decision with the imager. Are we happy to do it? Yes, no. And
similar question, the ACTH stim. Would you proceed with that in this case again?
Yeah, I think I was gilding the lily, if I'm honest, Lydia. I was working at teaching, in a teaching hospital residence, and we were, you do need to be certain there's no other possible thing that can cause it. A puppy like this, again, I think it was probably too much. I think maybe I wouldn't do it again, if I'm honest. If you've got a dog, though, that's slightly older, certainly 3, 4 onwards, that I would always rule out, ACTH or low dose dex. I think you've got to, even though I know Cushing's is really rare in patients who are 4 or 5. But I think with this puppy, I probably was a bit over the top, if I'm honest. Yes.
Sorry, it was a low dose dex in this case.
It was low dose dex, yeah.
And you mentioned that you would low dose dex because otherwise healthy. Do you kind of have an easy rule if someone's in practice between ACTH stim versus low dose dex?
As usual, it's going to be a several part rule. Okay. It all comes down to the sensitivity and specificity of the assays. Okay, of the test, the assays. So a low dose dex is more likely to pick up a patient with Cushing's than a stim, and actually it's less likely to give you a false negative. Okay, so if you can, a low dose dex should be what is the better test to do with a dog who you suspect has Cushing's disease. However, as Honey illustrated last time, the one time that you can get false positives with a low dose dex is you've got significant physiological stress or another obvious illness. And in those patients, an ACTH stim is actually slightly less likely to give you a false positive. Okay, and that's the balance, sensitivity, and specificity. So both are good. In routine, normal Cushing's, if there is such a thing, then I would do a low dose dex first, but I will never criticize a college as an ACTH stim. If you've got a risk of a significant other problem, so where we think we've got other infections, neoplasia, ketosis, diabetic ketosis, I would do an ACTH stim. Okay, both are good. It is about knowing that you can get false positives and false negatives with both.
Yeah.
The risk of an ACTH stim is a false negative. The risk of low dose dex is a false positive, but that's not common. The risk of false positive goes up when you've got other stress present. The other thing you can do, and maybe we could do a whole seminar on the Cushing's, couldn't we? I'm not urine cortisol creatinine ratios. Okay. Sensitivity is the way I think about, because they are very, very, very prone to getting false positives. So there's a really nice paper in JVIM looking at cats admitted to cats don't get Cushing very often, cats admitted to an American teaching hospital, and almost every cat they tested had urine cortisol creatinine ratio within an hour of admission consistent with being Cushingoid, just because the cats are stressed, they'd seen a vet and been stuck in the kennel, let alone the journey to the clinic. So UCCRs are woeful and have a really high false positive rate. So I would never use a UCCR to actively diagnose Cushing's. However, the reverse, though, is useful, because if you have a UCCR that is completely normal, it is highly unlikely that patient has Cushing's. Okay, so if you've got a patient that gets really stressed in your clinic, it hates getting the case, sees you and it's barking its head off, or you don't even keep it in the clinic for any time, let alone do 8 hours for a low dose dex, get a free catch urine first thing in the morning when it's been relaxed. Okay, it's slept. You submit that UCCR. If the UCCR comes back less than 30, i.e. totally normal, it's highly unlikely that patient has Cushing's. Okay. Now, if it's got obvious rip-roaring clinical signs, pot belly, thin skin, and then you can get a false negative. But that's one way you could do a little screen in patients who are difficult to manage in the clinic.
I think that's a really, really good tip, because we all know a few dogs that
we've all had them.
Just the sight of the vets, let alone a needle, is enough to make sure your test is going to be really difficult to interpret. So that's really helpful. Does anyone have any other questions? Please add them to the chat box. Thank you so much to everyone for coming along tonight. Really appreciate you turning up on your Thursday evening in August. I know you're probably all having holidays and other things, so we really appreciate you attending. And if you would like to know any more about the mentorship program and working with Rob, then please do follow the link in the chat box. But it's been lovely having you all attend tonight. Thank you so much for your time. And I think that's all the questions. So thank you, Rob. That was really brilliant presentation. Really enjoyed it, learned a lot. So thank you very much, and I hope everyone has a lovely rest of your evening.
Thanks, everyone. Thanks to you very much, Dean, and thank you very much for everyone coming. Really appreciate it.
Take care. Bye.
Bye.